Thank you. Okay, great. So hopefully the rest of the team will also copy that link, right? Because if we leave that Zoom link and it will be deleted from that screen, right? So today last presentation is based on the essay analyte, which is called RAS. The RAS means the renin-angiotensin-aldosterone system. So what are these analytes? Let's discuss about that. In this presentation, we will discuss about the overview of the RAS and the involvement in the hypertension of these analytes, and what is the solution from SNIDE from Megumi plate forms, and what are the parameters that we have an edge over the competitors. So let's start with the RAS overview. So what is the RAS? Basically, RAS is the renin-angiotensin-aldosterone systems. It's basically an hormonal system which regulates the blood pressure, fluid, and electrolyte balance. So the renin-angiotensin-aldosterone systems belongs to this. That's in the liver release angiotensinogen, then it's converted into a angiotensin 1 and then angiotensin 2. So in some cases, angiotensinogen convert into the kidney release the renin, which play a vital role to convert angiotensinogen to angiotensin 1. And then the lungs also release the ACE levels. So it's basically stimulate the signals to convert the active transport of the angiotensin 2. So here you can see that there is a decrease in the renal perfusion, just aglomerular apparatus. Then the kidney gives a negative feedback, and there's this inhibitory signals goes to the water and salt retention with effective circulating volume increase, and the perfusion of the jugular apparatus increase. So you can see that here when this angiotensin 2 is presence in that, and then the what happened is that it's also maintain the sympathetic activity. It's also maintain the tubular sodium potassium reabsorption and potassium excretion and water retention as well. And this also stimulate the signals for the arterial vasoconstriction, increase in the blood pressures, and it is also angiotensin to also have a pituitary gland, posterior lobe, ADH secretions, and then this this stimulatory signals go to collecting the duct for the water reabsorption. So this water reabsorption, retention, and the arteriovascular constructions, increase in the blood pressure, and the sympathetic activities are all controlled by these renin-angiotensin-aldosterone systems process. So if we go to the further about the RAS overview, there are two analytes in that. There one is angiotensin 1 and the other is angiotensin 2. So the angiotensin 1, it is basically formed by the action of renin on angiotensinogen. That's then occurs. It's appear to have a no direct biological activity and exists solely as a precursor to the angiotensin 2. So this sympathetic nerve system, that decrease the blood pressure, decrease the plasma sodium level and the adrenobeta adrenogenic levels, act on a JG cells, and then they produce the renin. And this renin have to play a vital role to convert in the angiotensin to the angiotensin 1 in plasma. So this angiotensin 1 in plasma then converted into angiotensin 2 in plasma with the angiotensin converting enzymes. So the angiotensin is converted into angiotensin 2 through the removal of C-terminal residue by the enzyme ACE. And then angiotensin 2 act at the CNS central nervous system to increase the vasopressin production and also act on the venous and the arterial smooth muscles. So you can see that these act on the artery loss and the vasoconstriction and then increase the blood pressure. And then some in kidney cases, it's in a sodium reabsorption and the adrenal cortex helps to release the aldosterone, and the hypothalamus thirst, and then the body one body fluid, and then they control the acid base balance in the body and the blood pressure controlling system. So if we go for the RAS overview, another analyte which is called aldosterone. You can see that the aldosterone is a steroidal hormone which is produced by the adrenal cortex glomerulosa in the adrenal glands. So this, it has a plasma half-life of under 20 minutes. So the aldosterone synthesis secretion is primarily regulated by the angiotensin 2 and the potassium levels. And this aldosterone support active reabsorption of sodium with associated with the passive reabsorption of water and active secretion of the potassium. So you can see that glomerulosa release that's the aldosterone and the cortisone, and then the reticularis and the medulla and the epinephrine and non-epinephrines are released by the adrenal cortex of the adrenal gland. So if we talk about more, so the renin is basically a spartic protein, and then an enzymes which is secreted by the kidney consists of 406 amino acids. So this renin activate the RAS by cleaving angiotensin to yield the angiotensin 1. Then this angiotensinogen, which is released by the liver with the help of renal renin, and then it's converted to angiotensin 1, and then this renin is released in response to the three factors. So a decrease in the arterial blood pressure, and decrease in the sodium load delivered to the distal tubules, and the sympathetic nerve system's activity actions that's helps to release the renin to convert angiotensinogen into angiotensin 2, 1 and 2. So the renin measurement is very important. Like renin has one as a renin activity, that's a PRA, and the renin concentration, that's a PRC. So the renin activity is AI generate rate, and then the renin concentration through the RIA and chemiluminescence amino acid techniques are detected through this measurement. So the two analyte series contains the 37 degree centigrade and the 4 degree centigrade. So the pH should be between 5 to 6. Inhibitors of the angiotensin 1 and 2 transformation is occurs, and then the generation greater than 60 minutes incubation, then RIA-assay for generate angiotensin 1, RIA-assay for endogenous angiotensin 1, and then RIA generated, RIA endogenous divided by the incubation time. So give you the PRA nanogram per ml per hour. So that's the AI generate rate is for the renin. So if we talk about the hypertension, so what is hypertension? So basically, the high blood pressure is called hypertension, and they may lead to some cardiac issues. If you talk about the blood pressure categorization, according to the American Heart Association and the American Stroke Association, there is an blood pressure category of normal, elevated, high blood pressure stage 1, stage 2, and hypertensive crisis. So on the basis of their systolic and diastolic blood pressures, that the blood pressure which is when the heart is beat is called as systolic, and the diastolic is basically a blood pressure when heart rests between the beat is called diastolic. So measured in the millimeters of mercury, mmHg is the unit for that. If the normal blood pressure is for the systolic, is 120, and the diastolic is 80, and if it's elevated, it's between 120 and 129, and diastolic usually remains less than 80. So for the high blood pressure stage 1, if it's between 130 to 139, it's considered as a high blood pressure stage 1, and the diastolic is also increased between 80 to 89. So that's in a high blood pressure. Stage 2 is that the systolic blood pressure higher or equal to 140 mmHg, and the diastolic is also 90 or higher. And stage 2, after stage 2, there is hypertensive crisis, you need to immediately contact with the doctors or the physician. It's the higher than 180 mmHg and the higher than 120 diastolic may leads to the some cardiac damage or some stroke condition that's need an immediate physician attention for your hypertension. So if we talk about the hypertension symptoms, which may not produce any symptoms in some cases, and they are also called a silent killer. So what are the symptoms and signs of hypertension? Headache, visual change, chest pain, dyspnea, and the frequent asymptomatic. These are the symptoms of hypertension. Hypertensive retinopathy, cardiomegaly arrhythmias, and the proteinurias. So these are the three major signs of hypertension. So if not properly treated, high blood pressure can damage the heart and circulation and the lungs, brain, and the kidney without causing noticeable symptoms. So, symptoms of high blood pressure may be present in those who have extremely high blood pressure. So, the mild high blood pressure or stage one or two, in some patient, they don't have symptoms to diagnose. So, the monitoring is more important. So, if we talk about the global prevalence of hypertension, that's high blood pressure in some patient. So if we go to hello, you can hear my voice. My voice is clear. Okay, okay, thank you. So according to the WHO feedback for the hypertension prevalence worldwide is rising between the age 18 plus. According to 2015 data for the age standardization estimated for both male and female, the prevalence in the continent wise and the country wise who have less than 20% shows in the yellow color, and those who have greater than 35% prevalence is in maroon color, and between 30 to 35% prevalence is in the reddish color. So if you see about the countries where the prevalence of between 30 to 35% are the Sudan, Nigeria, Mali, the African countries, the Mauritius, Nigeria, Ethiopia, and Yemen, the Middle East countries as well. And even in the Pakistan, Afghanistan, these are the countries where the prevalence of hypertension is more. And in the countries, if we talk about like more in the upper region of European countries, like Poland, like Germany, they have more prevalence of between 30 to 35% of prevalence of hypertension. So if we talk about between the 25 to 30% prevalence of hypertension, you can see that the Russia, the European countries, including some other countries of Mongolia, some Kazakhstan, and then some other countries like India, they comes under between the 20 to 30% of prevalence of hypertension. So if we talk about the China, the Australia, and the countries like Canada, United States, and if the countries including in the South America like Peru, Bolivia, Colombia, Venezuela, these are the countries where the hypertension is between less than 20%. So this is all our systolic blood pressure. And what are the criteria of the hypertension was if the systolic blood pressure is greater than 140 and diastolic blood pressure is greater than 90, they consider as an hypertension. So if we talk about the hypertension types, there are two major types. The first type is the primary hypertension, which is 90%. If we talk about the secondary hypertension, which is 10%. So the smoking tobacco, high sodium diet, low potassium diet, being obese, obesity, alcohol utilization, family history, and unhealthy behaviors, these are may leads to the primary hypertension. So the secondary hypertension due to some chronic kidney disease, narrowing of the kidney arteries, the endocrine disorder, birth control pills utilization, or a sleep apnea syndrome may also lead to the secondary hypertension as a known cause. But for the primary hypertension, which is a 90% of overall hypertension, they have no identifiable cause. So these are the risk factors. If you are having these risk factors, more the risk factor, so the more the probability of primary hypertension in without having any non-identical cause for that. So if we talk about the hypertension, that's a secondary hypertension. The secondary hypertension is overall the 10% of hypertension, which may include the chronic kidney disease, narrowing of the kidney arteries, endocrine disorder, and then we have to focus on the endocrine disorder. So in the endocrine disorder, there is a chromophene tumor in which catecholamine and the primary aldosteronism, that's the renin and aldosterone levels are increase. So the Cushing syndrome, the ACTH and cortisols are the markers to check the endocrine disorder for the secondary hypertension. So if we talk about the primary aldosteronism is also known as the Conn's syndromes, which is that's 10% of the people with the high blood pressures of the secondary hypertension may have symptoms. There is no symptoms. There's a muscular weakness, muscular spasm, excessive urination. That cause of that disease is the enlargement of the adrenal gland, adrenal adenoma, or maybe some adrenal carcinoma or family history may lead to this Conn's syndromes. In this Conn's syndrome, what are the markers which help them to diagnose this primary aldosteronisms? And this is the aldosterone levels and the blood pressure, and they may increase due to the cell membrane potential, and also the blood potassium and excitation of the muscles decrease. So these are the markers which helps to diagnose the primary aldosteronism with the clinical symptoms. So with the imaging, they can, with the help of imaging, they can identify the primary aldosteronisms. Radiological imaging helps them to identify the adrenal gland enlargement. So if we talk about more about the primary aldosterone classification, there is some surgical correctable subtypes like the aldosterone producing adenomas, like Elias Conn's adenomas, aldosteronoma, the renin-angiotensin unresponsive adenoma, or renin-angiotensin responsive adenoma, or maybe some primary unilateral adrenal hyperplasia or adenocortical carcinoma with aldosterone hypersecretion may lead to that. So the non-surgical correctable subtypes, idiopathic adrenal hyperplasia, the familiar disease, these are non-surgical corrective subtype for the classification of primary adrenal. So if you go for the algorithm approach to the initial evaluation for the patient having a suspected secondary hypertension. So according to American Family Physician Journals, the diagnosis of secondary hypertension and age-based approach is more important. So the evaluation of suspected secondary hypertension, there are some history, physical examination, and laboratory testings help them to acquire the blood pressure, rule out and diet and drug-related cause. So the clinical clue, see the table 1, if the children or adolescents, urine analysis, urine culture, and renal ultrasonography helps them to further investigate with echocardiography. So if no clinical clue, but secondary hypertension remains a concern, child rapid onsets and acceleration of the hypertension, restant hypertension. That's a young adult. They have MRI with the gadolinium's contract media and the CT renal artery, and the TSH value helps them to support the echocardiography. So the middle age adult or older age, the renin and aldosterone level along with the TSH levels helps to diagnose the polymorphy, sleep steady, and then go for a 24-hour urinary cortisol and 24-hour urinary fraction metanephrine. And also in the older adult, like MRI with the gadolinium's contrast media or the CT renal artery, TSH and urine analysis helps them to diagnose with the urinary 24 hours cortisol or the fraction and metanephrine cases. So these are the evaluation for the suspected secondary hyperthyroidism. And then algorithm is also for the identification of the screening of possible secondary hyperthyroidism. So with that finding of hypertension and the hypokalemia, the family history of primary hyperaldosteronism, or the presence of the severe and resistance hypertension requiring more maximum dose of the separate antihypertensive and early years of samples that for that. So if we talk about this stimulation, you can see that algorithm for the algorithm for the identification and screening of the possible secondary hyperaldosteronism. So you can see that the algorithm for the identification and screening of the possible secondary hyperaldosteronisms, and there is an stimulates the plasma renin activity, plasma aldosterone concentration in this setting of the discontinuing appropriate medications. And then there are three possibilities. Either the increase PRA and PAC with the aldosterone to renin ratio less than 10, or maybe some reduce PRA and increase PAC with the aldosterone to renin ratio greater than 20 and PAC greater than 15 nanogram per deciliter. So the reduced PRA and reduced PAC have also some other clinical evaluation. So in the first case, when the PRA is increased and PAC is also increased with the aldosterone to renin ratio is less than 10, this evaluation for the cause of the secondary hyperaldosteronism, including the diuretics use, the renovascular hypertension, renin secreting tumors, including the renin-most malignant hypertension, corrections of the aorta, nephrosis, cirrhosis, and congestive heart failure. Then the reduced PRA and increased PA with the aldosterone to renin ratio, and then the confirmatory finding on the captopril, the suppression test with the non-suppressed, and then they go for a process to algorithm for the confirmation of the diagnosis of primary hyperaldosteronism. If finding not confirmed, reevaluate repeating by manage as low renin essential hypertension. So on the basis of these results, they can differentiate into a primary hyperaldosteronism or the essential hypertension. So then the reduced PRA and reduced PAC help them to evaluate the congenital adrenal hyperplasia, exogenous mineralocorticoid use, and the Cushing syndromes with the Little syndromes and the Gilman syndromes and liquorice ingestions alters aldosterone metabolism as well. So this is about the hypertension algorithm for the identification and the screening of the possible secondary aldosteronisms. So the another management of the primary aldosteronism, that the case detection, diagnosis, and the treatment for the according to the Society of Clinical Practice guidelines. This is about the Journal of Clinical Endocrinology and Metabolisms. So if we talk about the algorithms, we recommend using the plasma ARR to detect possible case of PA in these patient groups. Like we recommend case detection of PA in the patient with sustained blood pressure above 150 and 100 on each of the three measurement obtained on different days. So with hypertension, blood pressure greater than 140 by 90, resistance to three conventional antihypertensive drugs, including a diuretics. So the controlled blood pressure less than 140 by 90 on four or more antihypertensive drugs. Hypertension and spontaneous or diuretics induced hypokalemia, then the hypertension and adrenal incidentoloma, and the hypertension and sleep apnea. So, on the basis of hypertension and the family history of early onset of hypertension and the cerebrovascular accident at a young age between less than 40. So, the all hypertension, first degree, the relatives of the patient with the primary aldosteronisms. So, this is the screening, confirmation, and then classification of the algorithm on the basis of algorithm that may help them to diagnose and treat the hypertension. So, patient with the hypertension that are increased risk for the primary aldosteronisms that can be ARR to decrease detect cases, then the aldosterone to the renin ratio, and then the confirmatory testing, then go for further no confirmatory testing if there is a potassium level is low, PAC is greater than 20, and then if the adrenal cortisol, and then if the surgery is desired, then they go for a unilateral or bilateral treatment with the MR antagonistic or treatment with the laparoscopic adrenalectomy. So in aldosterone to renin ratio, more sensitive compared with only the serum potassium and aldosterone test, and some more specificity compared with the only renin test. And in some cases, that eliminates the misdiagnosis, less than 1 centimeter tumor and non-functioning adrenal tumors. So the laboratory need to report the individual value for the both plasma and aldosterone concentration and the plasma renin activity, the with plasma renin concentration, as well as the aldosterone renin ratio. So this algorithm for the detection and confirmation for the subtype testing and the treatment of the primary aldosteronism. So if we talk about the hypertension, algorithm is the screening, and this aldosterone renin ratio cutoff value, depending on the assays and based on the weather, plasma aldosterone concentration, plasma resin activity, and the direct renin concentration are measured in the conventional or system international unit. So the confirmation and classification on the basis of the PAC and in the nanogram per ml, PRA is 30 and the DRC is 3.7, and then the ratio cutoff value depending on the assays and based on the weather, the plasma aldosterone concentration and renin activity, and the direct renin concentration are measured in the conventional or system international unit. So this algorithm is also helpful for the management of primary aldosterone or secondary hypertension as well. So the oral sodium loading test, the saline infusion test, fluorocortisone suppression test, captopril challenge test. These all confirm the aldosterone secretion has been inhibited or not, and then this can be lead to the further confirmatory. So the classification on the basis of that, the computerized tomography and the adrenal venous sampling is also helpful to diagnose and classify this hypertension. So the antihypertensive drug selection, which based on the plasma renin activity measurement with the patient having a uncontrolled hypertension who are taking one or more antihypertensive drugs, though they are at a second visit, they have to go for some this algorithm is followed, and that will be helpful for them. So what are the SNIBE RAS parameter solutions which are provided by the SNIBE from SNIBE platform? So that's the comprehensive menu, which are exclusively provided by the SNIBE. We have aldosterone, direct renin, angiotensin 1, angiotensin 2, cortisol, and ACTH for the diagnosis of the hypertension, either the primary, secondary, and the aldosteronisms of the primary as well. So neither the Roche, Abbott, Simmons, and Bachman They do not have a comprehensive manual like the SNIBE for the hypertension conclusion, as the diasorin has in the more parameters, but they do not have angiotensin 1 and 2 assay from their platform. So we have a very comprehensive platform for the test menu for that. If we talk about the parameters like angiotensin 1, they have angiotensin that 2, the first generation and the second generation assay. We have a 50 test and 100 test pack size. We have a principle of quantitative and competitive principle, and the human plasma is recommended for that, and 100 microliter sample volume is required. As per the standardization, we have an isotope dilution mass spectroscopy and TMS traceability for the calibration of that assay and the standardization of that assay. And then calibrator controls include one level of QC in both in the angiotensin 1 and 2 assays as well. So if we talk about the calibration interval for the angiotensin 1 and 2, onboard calibration interval is 1 week. The limit of blind detection in one is 0.1 to 0.15, and the angiotensin 2 is 5.0 to 7.5 picogram per ml. So the time to the result on M2000 is just 20 minutes and then 27 minutes on M4000P. Within the run precision is less than 5.58, while the angiotensin 2 assay simple precision is 4.81% less than. So the total overall precision is less than 8% in angiotensin 1 and 2 enzymes. So that can be used as that. So if we talk about the second generation of angiotensin 1 and 2, they have a quantitative analysis, human plasma is recommended, and the traceability and standardization according to the global guideline of WHO internal standard of 70 by 302 for angiotensin 2 and 86 by 536 by angiotensin 1 enzyme. So the calibration interval is 28 days, which is a more reliable and onboard, more better stability as compared to the other. The dilution for the high samples are also recommended, along with the limit of blank detection quantitation. And then within run precision is less than 3% and less than 3.24% in second angiotensin 2 in the second generation assay. So the overall reproducibility is less than 5, which shows that our assays is second generation is better than the first generation assay. So the angiotensin 1 kit components, they have anticoagulant, the enzyme inhibitor, pH regulators, and the dimethylone is all provided. They are ready to use, and then they require some preparation for that. For the angiotensin 1 kit component, there are 4 components that need to be prepared, or if they are prepared, then they need to be transferred in their respective compartment. Like anticoagulant, and enzyme inhibitor, pH regulator, and dimethylpropyl are included in that kit, and they are ready to use. So how to run the PRA, that's an angiotensin 1. So sample collection, then the preparation for the analysis, calculation, and the setting. These are the 3 major steps for how to run PRA. So the collect blood aseptically using the precaution for the manufacturer, and then add the anticoagulant and enzyme inhibitor by the ratio below. Like if you are collecting whole blood in one tube of 5 ml, then you have to add 50 microliter 0.30 molarity EDTA, dipotassium EDTA, and then you can add the 50 microliter from that to the tube. Plus, you have to add 25 microliter 0.32 molarity dimer caprol, and then plus 50 microliter enzyme inhibitors. So the anticoagulant should firstly be added into the blood before the enzymes inhibition. So that's an anticoagulant is that it's a dipotassium EDTA. So if using the vacuum tube with anticoagulant additive, then please make sure that the EDTA, dipotassium EDTA or tetrapotassium as an anticoagulant. So tripotassium EDTA is not recommended or not evaluated. That's why whenever the customer is going to testing the angiotensin, they have to make sure the recommended type is the EDTA, dipotassium EDTA, or is a tetra sodium EDTA tube as an anticoagulant is recommended. So in this situation, there's no need to add an anticoagulant, only add dimercaprol and the enzyme inhibition directly. So, but if you have an anticoagulant, you have to add into the blood before the enzyme inhibition. So the enzyme inhibition and dimercaprol are that. If the volume of the sample is different, please increase or decrease the reagent to the same proportion. So this step is also important. If you are taking a 5 ml blood, then you have to take 25 microliter dimacrol and 50 microliter enzyme inhibition. But if you are taking a 3 ml of blood in the dipotassium mediated tube, you have to reduce the ratio of dimercaprol and the enzyme inhibitor as well. So if you go for a parameter one, angiotensin one, how to run the PRA, you have to collect the sample, preparation for the analysis, and calculation and settings are recommended. First, you have to mix after sealing up the tube with the cap, turn the tube up and down several times for the mixing, and then ice bath. Place the tube in the ice bath or a 4-degree refrigerator for 1 to 2 hours. And then centrifuge the tube for 7 minutes with 4020 RPM per minute, preferably is refrigerated at 4 degrees centigrade to separate the plasma. So if the plasma needed to be stored for the longer period, you have to please seal and store the refrigerator below minus 15 degrees centigrade because the angiotensin 1 enzyme half-life is comparatively low. So if you go for a further how to run then you have to plasma should be divided into two parts. Both of the two parts should be added with the pH regulator by 1.8 ratio, 100 microliter of pH regulator plus 800 microliter of plasma to adjust the specimen pH value. So on one part should be kept in the ice bar or water bath to 0 to 4 degrees centigrade directly. The other part should be incubated in 37-degree water bath for 1 hour and then kept in the ice water bath 0 to 4 degrees centigrade until the temperature of the two bar part is the same. So then load these two parts of sample together to the analyzer and test them together. So once you have run the samples and then the plasma renin activity PRA is equal to A1 concentration in 37 degrees centigrade minus A1 concentration in 4 degrees centigrade. So then you can collect the PRA. So when you have this angiotensin 1 kit component, they have an enzyme inhibitor and pH regulator. So you can use that. So how to run that? This is the plasma type. This is the preparation for the analysis given. And then this is the calculation through which that can. So is also you can use a special setting in the system that definition test AI and then the special testing. Then you have to click apply and then input sample size, the range of 4-degree sample ID, the range of 37-degree sample ID, and then you can calculate and setting the results. So the sample collection and the preparation for that, now this step this is the calculation setting. So how to calculate and setting, then upgrade the software to the latest version, which comes with the PRASA. So the PRASA is shown here. You have to go for the further angiotensin 1, how to run the PRA. You have to calculate result with automatically display the report of the test is completed. So you can check that how you can run that. Okay. So the angiotensin 2 kit component is also contain dimercaprol and enzyme inhibitors so that new reagents are present are used to use. So angiotensin 2 samples pre-treatments are also more or less same that you can use that after sealing the tube. That's the recommendation to mix with that and then they can store, can be converted and then this is the process for that. So if you talk about the angiotensin 1 result analysis interpretation for the plasma running activity at the 37 degrees centigrade, is that from the normal diet on the lying position and the standing position is the reference value is different. For the angiotensin 2 result analysis, interpretation of the reference range of normal diet with the lying position and then standing position is the reference value is different. So the reference ranges of the standing position is higher than the lying position. You can see during the sample collection procedure, the operator should pay attention to the patient position and should mention on the sample type. So the second generation of SNIPE angiotensin 2 kit components contain the control 1 and control 2 along with the enzyme inhibitors and the conventional magnetic microparticle beads, low and high calibrator and with the buffer and API label. All reagents are ready to use. If we talk about the pre-treatment, yes, there is a pre-treatment procedure for that. 2 ml EDT tube or 5 ml EDT tube. There are two options. Either you have to put 20 microliter enzyme inhibitor or 50 microliter enzyme inhibitor in that. Prepare for the analysis. This is a procedure given in the package insert. And if we talk about the interpretation, they have angiotensin 1 results analysis on the basis of line position and the standing position, and you can see that the reference age is higher than the line position. So if we compare the aldosterone assay with the disorin lysone aldosterone assay, you can see that we have a 100 test and 50 test pack size. Along with that, in its second generation, we have a 30 test pack size, while the disorin has only 100 test pack size. We have a competitive assays in the first generation, but in the second generation, we have a sandwich principle. The disorin have introducing competitive assay. We have just 50 microliter in the second generation as compared to the 100 microliter in the first generation, while the disorin required 250 microliter for sample volume for performing a single test. Calibration interval is a 1 week. In the first generation, we have improved 4 weeks, while the Sorin has a 1 week calibration. So if we talk about the dilution, aldosterone first generation dilution was not recommended, but in the second generation, if the results are higher than 2000 picogram per ml, so they can be diluted with the ratio 1:50, but it should be value greater than the 40 picogram per ml. This is important point that need to be discussed, because the linearity is 2000 picogram per ml, and they are recommending that sample must be greater than 40. So the reason is, ideally the dilution is recommended for those samples whose values are greater than 2000. But if you want to run the dilution of sample which are less than 2000, but they should be higher than 40 picogram per ml if you want to run the dilution. So the limit of blank, limit of detection, and limit of quantitation is also explained in a well manner in the second generation as compared to the first generation. And the measuring range is comparatively better than the other competitors in the market. So if we talk about the first generation aldosterone kit component, all reagents are ready to use. They have magnetic microparticle beads, low and high calibrator, displacing reagent, and the FITC and ABI level along with the internal quality control. So if we go for aldosterone blood sample pre-treatment, so the serum and the plasma both are recommended. So the standard sample tube, that's tube containing a separating gel. So there is a one question, okay, to everyone. This tube is called a vacutainer tube. Inside, it's a silicone coated. What is the reason to coat a gel tube, gel separating tube with silicone? What is the role of silicone in the serum separating tube? Any answer? This yellow top tube, from inside, it is coated with the silicone. What is the function of this silicone? Easy to centrifuge? No. Any other option? Any other option? Oh, it's okay. To prevent coagulation, with wall to avoid. Okay. Okay. So as you know that there are two tubes required for the serum separation. One is called a red top or a plain tube, which has no gel in it. Only the blood goes collect in that tube, and you have to place 15 to 18 minutes for the natural clotting of that sample, right? But in the yellow top tube, there is a gel which act as an inert material for the separating medium of RBCs and the serum from to create a separating media. And the inside this tube, this is a silicone coated, and this silicone coated is to enhance the as an clotted activator and enhance the activation process. So this silicone coated tubes, when you put sample in it, it enhances the process of clotting, and due to which the yellow top tube clotting time is less than the red top tube. And the second thing is after centrifugation, if you are using a good centrifugation, you can directly refrigerate or freeze that tube in the freezer. But if you have a red top tube which has a no separating media, only a tube, plain tube, which has only blood, and after the natural clotting of 15 to 18 minutes, then you have to centrifuge it. You cannot use this tube directly for the 2 to 8 temperature storage and the minus 20 storage, because the hemolysis may have impact to destroy the serum integrity and convert into a hemolysate samples. So that's the reason why the silicone coated tubes or yellow top tubes are having more clinical utilization as of today for the serum separation. While these plasma tubes, they are also major tubes used in the hematology section is the purple top, which are either the dipotassium EDTA or a tripotassium EDTA. So for this assay, if the dipotassium EDTA is validated, so you have to use the dipotassium EDTA, otherwise the tripotassium EDTA is the tube required. So this is a lithium heparin anticoagulant tubes. When you mix the sample in it, it's contain a fibrinogen and other liquid containing in the plasma. So these are centrifuge, and you can get a clear plasma from that. These are anticoagulant tubes. So usually they are 5 ml or 3 ml tubes. You have to see the tubes manufacturer's recommendation on the tubes, so they can help you to required volume you can mention there. So if you go for a So if you go for a aldosterone urine sample pre-treatment, you have to collect 24-hour urine, keeping the specimen refrigerating during the collection, and you have to measure and record the total volume. So the fresh collect urine sample is stable for 5 days when stored at 2 to 8 degrees centigrade, for 4 weeks when stored at minus 20. So they have also shows for some aldosterone samples stability at minus 20, and they recommend you for the store up to the 4 days and up to 4 weeks, 5 days, and up to the 4 weeks at minus 20 degrees centigrade. So once you have thawed that sample, then you have to mix well before withdrawing the part urine, and then add this into the two-part urine, then 1 ml urine and 2 ml urine hydrolysate. And then mix thoroughly by vertex or rotator before incubation overnight for 20 to 24 hours at 30 degrees centigrade. And then when withdraw one part of hydrolyzed urine sample and mix thoroughly with one part urine neutralizer, that the 400 L hydrolyzed urine sample and 400 L urine neutralizers. So they inspect all specimen for the bubbles and remove bubble before analysis for the optimum result. So it is suggested to test the timely. If it's not going to be used timely, it is recommended to store the treated urine sample and untreated urine sample at minus 20 degrees centigrade, because the hydrolyzed and neutralized urine preparation are stable for 4 weeks, then stored at -20, and mix the thaw sample well before testing if your urine sample is stored as a frozen. So these are the recommendations for the sample handling for aldosterone. So the aldosterone results analysis is calculation is based on the urine sample, like urine aldosterone of 24 hours microgram is equal to the testing results in should be the picogram per ml multiplied by 6 multiplied by 24-hour urine volume and then multiplied by 10 to the power -6. So this is the formula to check the urine aldosterone in 24 hours in terms of microgram. So the results and the reference range for the apparently healthy people is between 1.0 to 8.0 microgram per 24 hour is for the urinary aldosterone. So the reference ranges for the serum and plasma is based on the position, like the lying down position or standing upright position is a 70 to 300, and the lying down position is 30 to 160. So the upright samples were collected from the individual after standing at least 30 minutes. So the lying down sample were collected after the individual lying in the supine position for at least 30 minutes. So all these two position samples collection depend upon the 30 minutes staying the person at that position. After that 30 minutes, you can collect the sample and mark as a lying down or standing upright position. So this is the aldosterone kit. All reagents are ready to use, including the magnetic microparticle beads, low and high calibrator, the buffer, ABI label, dialment, and the control 1 and control 2 are also available. If we talk about the sample pre-treatment, that's the sample tubes and all the serum plasma urines are recommended, and the urine sample pre-treatments are also mentioned in that area. If we talk about the aldosterone urine sample pre-treatment, they have a sample release agent. That's the list number is also given. They have also purchased order for the urine hydrolyzers and neutralizers, and the aldosterone result analysis is depends upon the interpretation of the results of apparently healthy individual in China. Number is 555 serum samples. So the 297 urine sample apparently healthy individual in China. So they have a urine sample of having a mean value of 10.57, and then 97.5 percentile is 30 microgram per day. So if we compare the direct training technical specification with the first generation Brennan, second generation Brennan, with the diasorin Brennan, we have an edge of 30 tests, 50 tests, and 100 tests in our direct training assay as compared to the first generation of having a both 50 and 100 test pack size. And in compared to the diasorin, they are only offering 100 test pack size. We have a quantitative and sandwich principal sample type, EDTA plasma, and the 100 microliter sample volume is required as compared to 355 microliter sample for the diasorin assay. We have a standardization against the WHO International Standard of NIBSC code 68-356. We have included the ready-to-use two level of controls and the calibrators, while the calibrated controls are lyophilized in diasorin case, and then the calibration interval is the 2 weeks as compared to the 4 weeks of diasorin. We have LOB, LOD, and LOQ concept in that assay with the 0.5 to 0.8 and 1.0, and they have a 0.52, 0.97, and is a linearity of that assay. So the test time in this first generation was 34. For the SNIB and diasorin is not available when within the run precision. We have a less than 4.11% precision value within run precision as compared to 13.03 diasorin value. So in terms of accuracy, reliability, and precise results, our precision value shows an excellent correlation with the patient test reliability and assay performance. So if you talk about the direct training kit component, that you can see that they have a microparticle beads, low high calibrator, ABI label, control 1 and 2, and the reagent provide ready to use with that assay. So this is specimen collection and preparation procedure with the SNIB, the renin assay. This is analysis of results. This is second generation renin kits, which include the magnetic microparticle beads with low and high calibration and ABI, and the renin 1 and 2 level of QC, where a concentration of 40 and 105 micro IU per ml. So the direct training sample pretreatment preparation of the analysis is also given. So once the customers wants to start these essay, we have to tune them. They have to review all these package insert very carefully, just not only to interpretation of the result, also with the sample preparation. So if we talk about the difference between PRA and PRC, so direct training assay can measure low concentration of renin in sample with good correlation and the low coefficient of variation. So this suggests that the direct training method is an adequate method for the measuring sample with a low renin concentration, and its possibility is a suitable alternate for the measuring renin in the black individual. So the advantages of high throughput with the DR direct training assay could facilitate the measurement of renin in the population-based study and aid in the screening of secondary forms of hypertension. So including the primary aldosterone and the little syndromes are though that can be helpful for that case of PRC. So this is all about the renin and hypertension cases. If you have any question, you can ask or we can discuss as well. So if you have any question, you can ask. Otherwise, we have to close today's session. Till we have 18 minutes. So if you ask, so we can use that things for some purpose. So I would like to ask you a one question. So I hope you have copied the training feedback. So my question is this trainings that which I have given you since 2-3 weeks, it's good, or any suggestion for my training improvement plan? Okay, thank you, Anton K. But if you have any suggestion, like where's my friend Roman? Roman, how are you?
I'm fine.
So, any suggestion for my training? If you have, you can share. So, because I want to do some more experiment and I want to have to involve more of you. Honestly, I try to involve everyone from Russia to participate in the training, and in some cases, I have create some questions, and I would like to involve all of you. And in my mind, there is a one idea. I'm working on it because the artificial intelligence is now these days are very much emerging field of IT as of day. So what I am doing, I'm making some videos of these presentation in my English language, and I'm trying to contact with some AI software companies who can convert my presentations video into a different language, like Russian language, like Chinese language, like French language. So they maybe a good opportunity for those who have some language barrier, because sometimes it's very difficult for China in China to explain some some thoughts or some experiences in the English language. So the level of communication and understanding will be excellent if we create some videos in Russian language, in some Chinese language, or in some French language. So this is basically just an hypothesis in my mind. So I'm trying to work on it. And let me check. There are a few sites which are a paid sites which wants some money to convert that video. But unfortunately, my all videos are more than 1 hour, 30 minutes, 1 hour, 50 minutes, 1 hour, 60 minutes. So they may charge more. Let me try one or more videos and let me do that experiment. It may be a very helpful for all of us. So is it a good idea if I convert my English presentation recorded into the French or a Russian language or a Chinese language? Okay, thank you, Anton. So, if you have any question, let me check one thing. Let me check one thing. If you have a time, because we have still 14 minutes, I have to check one thing and I give you the about there was something that was a okay. I go to I talk to like okay. Okay. So I have to type this as mhm. Not yet immunoassay. Immunoassay. It's an Okay, so you can see my screen. So yesterday, in infectious disease essay, we have used the word of sensitivity and the specificity. So what is sensitivity and what is specificity? What is accuracy and what is precision? So these are the basic terms that we are using in the laboratory, right? If we talk about the accuracy, so the accuracy means hit the right target. For example, if a patient glucose level is 145, and when you run on your analyzers, it gives the result 143. It means your results are accurate. Okay. But if your result run 10 times and the target value was 145 and your results come 143, 142, 144, 145 and 146, it means your results are accurate and precise. But if your result is 86 and the target value was 146, so it means your result is inaccurate, which not hit the right target. Okay, so I can explain you in this area. If your result is here, right? I have to make some more thick mark. Okay, so if the result is your here, it is called inaccurate results. But if your results is here and it's consistently you run multiple time, it comes here, it's called inaccurate but precise. But if the results are continuously comes with in this area, this is called precise result, but it's not close to the target. They are far away from the target. It's called inaccurate results. If the concept is clear about the accurate and precise. And if we talk about the sensitivity and the specificity, the sensitivity means ability to exclude the false negative. What this means false negative? The probability of missing the target molecule is zero is called sensitivity. So if you enhance the sensitivity or you keep the 100% sensitivity, your specificity will not be 100%. And what is specificity? The specificity is ability to exclude the false positive. So this is a double-edged sword. Your instrument could generate in infectious assay neither false negative, neither false positive results. So the sensitivity and specificity should be close to the 100. So if your assay sensitivity is 99.92 or 96%, so it may have a specificity of 99.86, right? So it may give 14 results false positive out of 1000 samples if the specificity is 99.86. And if the 99.96 is the sensitivity, so the system may give 4 samples false negative probability among 1000 samples. Among 1000 patient samples, the 4 samples may gives you the false negative results. So the important thing for this sensitivity and specificity is Nobody is 100% in infectious like hepatitis B, C, and HIV. So this clinical sensitivity and specificity are typically thoughts of a subset of the accuracy, and then accuracy and precision. If an assay has the ability to accurately and reproducibility generate the result that does not produce the false positive, then it is considered specific. A false positive means that a result may incorrectly indicate a certain patient condition exists. The positive result does not really identify a patient who is positive. In hepatitis testing, for example, a false positive the false positive means the assay indicate a patient is positive for hepatitis when he or she is not. This can occurs for many reasons, but in the most instance, it is because the assay methodology cannot distinguish between the desired and a light. So this is the basic concept for the accurate, precise, sensitivity, and the specificity. So there are few questions related to some more indication. Like if I goes to the next page, they have a calibration traceability concept. We have some more assay interferences, Hooke's effect, false positive due to the HAMA, and then heterophilic antibodies interference, or you can see that the definition of clinical sensitivity and activity. So there's a few quiz. If I ask you a question, the simple question, the ability of an assay to reproduce hit a target concentration is referred to as what? If I ask you the question here, which is the right answer for this? The ability of an assay to reproducible hit a target concentration is what? Good, excellent. The precision, it's the reproducibility. They are talking about the reproducibility hit a target concentration. So another is the interference from HEMA can be eliminated by utilizing two-step immunoassay. Yes, can be related. It's not related to the us. And if we talk about more essays, like a simple one, this is more. This is very much interesting chapters inside that. That different have some different information for that. So that was all about which I have missed yesterday about to explain you this important topic. So if you have any question, you can ask. So otherwise we can. So any question if you have, otherwise we have to close the today's session. And I hope all of you copy the link for the training feedback, or if you have any suggestion for me to have more improvement in the training plan, I will appreciate your comments, your valuable feedback. So how we can improve this session or a learning session as an interactive session. So I wish if all of you ask so many questions and I have to give you the right answer, or if I do not have a right answer, I can arrange a right answer for you. Okay, thank you very much. If everything is clear, everything is okay, so we can close the today's session. And Thank you very much for joining us together, and have a nice day, and take care of yourself, and goodbye.